Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Madelyn Johnson, a PGY2 emergency medicine resident from the Mayo Clinic, who will be presenting on the FASTEST trial. This is a multi-center, double-blind, randomized, placebo phase 3 controlled trial.
So a little bit of background. So intracerebral hemorrhage is a brain injury that's attributed to acute blood extravasation into the brain parenchyma from a ruptured cerebral blood vessel. There's two common underlying cerebral small vessel pathologies that account for a majority of these primary ICHs. We have the arteriolosclerosis and cerebral amyloid angiopathy. And when this bleeding occurs, brain injury occurs through a few different mechanisms. First, through the hematoma expansion, which expands most within the first few hours after the acute injury and after the onset, which then causes an increase in pressure inside of our cranial vault and can cause further injury to the brain tissue. Other secondary mechanisms of injury include cerebral edema that's also occurring within the cerebral vault, inflammation, and biochemical toxicities from the blood products such as hemoglobin, iron, and thrombin that all irritate our brain tissue. Altogether, these injuries factor into the pretty high mortality rate that can occur with intracerebral hemorrhage, upwards of 30 to 40%, kind of where you look within the literature. And so we have to come up with a multimodal management strategies to try to terminate and best mitigate these high mortality rates. And so the guidelines talk about a few different things that we can aim to do, but there's not a specific treatment to fix ICH. So a couple of different steps we can take. First, they talk about blood pressure management. So targeting a systolic blood pressure anywhere from 130 to 150. If a patient is anticoagulated, anticoagulation reversal is recommended during the guidelines. Pending neurosurgery, platelet transfusions can be recommended. And then trying to prevent hematoma expansion is kind of the bottom bucket of the management strategies and where we're going to try to focus some of our attention today with this trial. And so diving into hematoma expansion a little bit further, there's been pooled analysis and subgroup analysis of randomized controlled trials that have demonstrated that hematoma growth is a crucial and independent determinant of both mortality and functional outcomes for patients with intracerebral hemorrhages. The specific volume as to which we want to try to reduce or prevent our hematoma expansion to occur is a little bit variable, with some of our older literature noting that 3 to 4 mils may make a significant impact. But some of our newer literature and analysis from the trial we'll talk about today talks about potentially this impact isn't seen until we kind of get into that 6 to 12 milliliter bucket. The other piece, though, to talk about is the time in which that is occurring. So the earlier management is instituted in these patients, the better functional outcome and decreased risk of death has also been found in studies, further enforcing that one concept that we've all learned back in school, that time is brain. And so to try to prevent this hematoma expansion, this is where one of recombinant factor 7 comes into play and is one of our management strategies. The guidelines mention as a class 2B recommendation to aid in preventing the hematoma expansion. So factor 7 interacts with tissue factors at the site of vessel injury, which leads to thrombin generation. In addition, factor 7 activates factor 10 on the surface of activated platelets, leading to an enhanced thrombin burst at the site of the injury. All in all, thrombin together converts fibrinogen to fibrin, producing a stable clot and potentially leading to the decrease in hematoma expansion. Some of the risks, though, that come with factor 7's use, so that's not a benign medication, is that risk of increased thromboembolic events, so increasing our risk for myocardial infarction or ischemic stroke, and is often one of the safety outcome measures in the trials that have studied this medication. And so jumping into some of our previous literature, kind of where factor 7 came to be, there's two randomized controlled trials that I want to talk about today. Number one, the first to prove its kind of place a little bit in the guidelines, we have to touch on the phase 2B trial, which was conducted to determine whether this recombinant factor 7 can effectively reduce hematoma growth in patients with acute cerebral hemorrhage, and thus then hopefully improving their outcomes. So they conducted double-blind randomized control trial in patients with intracerebral hemorrhage that was documented or determined by a CT scan within 3 hours of their symptom onset. Patients were then randomly assigned to receive a single IV dose of 40, 80, or 160 micrograms per kilo factor 7 or placebo. Looking at their outcomes, their primary outcome was looking at the hematoma expansion size by utilizing follow-up CT at 24 hours. And with that, they showed the smallest increase in size with the 160 microgram per kilo dosing strategy compared to placebo, and found a statistical significant difference with the 160 micrograms per kilo dosing strategy. And then the farthest column, which is combined or combining all of the data from each of the factor VII dosing strategies. Functional benefit was also found in this trial at doses of the 80 micrograms per kilo and in that combined group compared to the placebo. Where they did not find statistical significance was within the mortality bucket, but potentially we could deem this as clinically significant without an increase in the thromboembolic events, but noting that potentially at that higher dose of 160 micrograms per kilo, that did institute the highest amount of thromboembolic events. So all in all, big takeaways from this trial was that there's limited hematoma growth with factor VII use. It's potentially is improving some functional outcomes, and that there potentially does not seem to be any statistical significant increase in thromboembolic events in their analysis. Which then dives us into the phase 3 trial, or the FAST trial, in which the perceived benefits leading to this phase 3 trial now is focusing on, or they're looking to evaluate more so the functionality piece of this. So we're seeing maybe this decrease in hematoma growth, the earlier trial, but what does that correlate to as functional outcomes as our primary outcome? So they completed double-blind randomized control trial again in these adults within 4 hours, though, of their symptom onset, confirmed by CT imaging as well. Patients were randomized into 3 different buckets: a placebo bucket, a 20 mics per kilo dose, or an 80 mics per kilo dose. The 160 micrograms per kilo dose was not utilized in this trial, and also not utilized in our fastest trial that we're going to talk about today, due to some findings that of a pooled analysis where the doses upwards of 120 mics per kilo were associated with a greater risk of arterial thromboembolic events. And so for that reason, they did not utilize the higher dosing strategy. And so if we look at their outcomes, their main outcome that I discussed was the functional outcome here, was the primary one, in which they did not find any statistical significant difference, functional outcomes at day 90 or in mortality. They did not identify any increased risk of thromboembolic events, though, with the factor VII use. Where they did find a difference was with that hematoma growth again, in both dosing strategies, finding a reduction in that growth. But in an exploratory post-hoc analysis in this study, they found functional benefit among subjects who were less than 70 years old and had a baseline intracerebral hemorrhage volume of 60 milliliters or less, with intraventricular hemorrhage volume of 5 mils or less, and the time of onset of symptoms to treatment at 2.5 hours or less. And all in all, those patients receiving 80 mics per kilo of factor VII. And this subgroup analysis was important as it led to the foundation of the fastest trial, or our trial that of interest today. And so fastest trial, multi-center prospective, double-blind, randomized, placebo-controlled phase 3 trial, conducted across 93 sites in 6 different countries. Within this, they then included patients 18 to 80 years old. That volume now of your intracranial hemorrhage was anywhere from 2 to 60 milliliters. Patients had to have a GCS greater than 8, no recent anticoag use or thrombotic events within the past 3 months, and they were able to receive treatment within 2 hours of symptom onset. So noting that this time frame is getting a little bit more narrow as we learn more about the medication and its effects. Some of the exclusion criteria in this study is that patients were excluded if they had a intracerebral hemorrhage noted to be from an aneurysm or traumatic brain injury, they had evidence of a semi-apron presentation, thrombocytopenia, or evidence of a brain stem hemorrhagic stroke, as they deemed there would likely not be any benefit in those patient populations. And so these patients were then randomized in a 1-to-1 fashion to receive placebo or the 80 micrograms per kilo dosing strategy that we had discussed is maybe where they found that benefit from the subgroup analysis of the FAST trial. This was administered over 2 minutes IV push. So the key outcomes that they looked at, their primary outcome was again a functional outcome at day 180 now instead of day 90. Very similar approach to the FAST trial, where our secondary outcomes and safety outcomes encompass our volume change in hematoma, thromboembolic events, and mortality. And so if we look a little closer at the baseline characteristics, it seems to be well-balanced cohorts within the intention to treat protocol with a total of 626 patients enrolled. Noting here, though, that they did not meet their power calculation that was conducted. And a majority of these patients were of the Asian descent, as Japan had the largest amount of enrollment within the trial. Our average time to intervention, I think, is important, noting that this was around 100 minutes in both group, which is under that 120 minutes that was set apart in the inclusion criteria. So I think that's a positive thing from the trial. And then finally, about a third of the patients within this study had a spot sign on their CT imaging, meaning that they're likely still having ongoing bleeding at the rupture site, as it's showing the contrast on their CT imaging. And so primary outcome, like we had talked about, was functional approach here. So they looked at the modified Rankin scale at day 180 and their intention to treat patient population, in which they found no difference in the intention to treat group and also not a difference in the per protocol analysis. There was 32 patients who did not meet the per protocol analysis, and so were removed. But noting that there was no difference, I think, is important between the two groups. This finding does differ from that 2B trial findings, but similar findings to that of the FAST trial, noting though that these outcomes are measured at day 180 instead of day 90 from those other studies. From a secondary endpoint perspective, that they did look at the modified Rankin scale at day 90, in which there's likely not a difference observed. They didn't have a statistical analysis, but noting from the numbers and percentages here, likely would not find a difference clinically. No difference is noted. They also did observe a significant difference in the intracerebral hemorrhage volume, and this is kind of where a consistent result that we see factor 7 to be noting in all of our studies that we've talked about today, but noting that it's potentially still not making a clinical impact on these patients from a functionality or even a mortality standpoint, as there was no difference in mortality in either one of the groups. One of the secondary safety outcomes that I think is important to discuss is the thromboembolic complications, in which they did find an increase in these at day 4, but not in day 90. Which I can't say I'm entirely surprised by the findings, as we potentially would expect this by giving someone a factor product to have a higher rate of thromboembolic events. And we also potentially saw this trend with a higher dose in the 2B trial. But I think it's important to note that these thromboembolic events or complications did not significantly impact our mortality or functional status within these patients or within the trial that was noted here. The other point that's, I think, a little more interesting for this trial is a subgroup analysis. They had a pre-specified subgroup analysis that they ran, and they reviewed primary outcome of our modified Rankin scale at day 180 in a plethora of different subgroups. And I think where it gets really interesting is looking at these two here, where the time since our last known well and how fast they administered the product, and our group that had presence of a spot sign on the CT imaging, which these two, though they're not statistically significant, I think had the greatest shift, as we can see from the forest plot here, potentially maybe a patient population where we can would find a little bit of benefit. They followed this subgroup by an exploratory analysis as well, and this suggested that the greatest potential benefit of our factor 7 was in patients who had both a spot sign on their CT imaging and were treated within 90 minutes of last known well. Also noted that this group had a decrease in hematoma expansion, and so I think now maybe this is the group that we're finally seeing the potential benefit, where we are seeing both a decrease in our volume or no growth in our volume here and a difference from a functionality standpoint. The last part, though, I want to draw your attention to, though, is the size of this patient population, noting that our N here is very, very small, representing how very niche and rare potentially this can be to catch at such a rare spontaneous intracerebral hemorrhage that actually is occurring. Patients present and are into your emergency department within 90 minutes and able to receive treatment. I think it can be can be challenging. So the authors concluded here that recombinant factor 7 administered within 2 hours of intracerebral hemorrhage onset slowed hematoma growth, but did not improve functional outcomes at 180 days in patients with spontaneous ICH. Additionally, this agent was associated with a small increase of the life-threatening thromboembolic complications at day 4. I think this is a fair conclusion based on the data and what they've presented here with their findings. But I think some further strengths and limitations that I want to discuss, I think there is some positives that come from this study. Number one being the functionality as a primary outcome. I think that is a great patient-focused primary outcome for a study. Like I talked about in the 2B, noting that our volume size may be able to be decreased, but if we're not actually seeing a functional benefit, I think that can play a large role into how the medication can be utilized. I think this study holds high amount of external validity with a broad range of patients represented from a global perspective, noting that there was more of the Asian descent, but I still think broadly there was a lot of patients included from all over the world. So increasing good external validity from that point. And then finally, the analyzed results within the intention to treat and the per protocol patient population and found similar results in each of these, which I think is great. And there was also a low exclusion rate from the intention to treat patient population, with most of these patients becoming because they didn't receive the intervention within the 120-minute time window. And then finally, the blinding of the study. I think this is also super important, especially when we're measuring functional outcomes, to limit bias that could be introduced by some of the providers looking at that for patients. Some things or limitations I think to look at and to further expand upon. I think earlier cessation of the trial due to the lack of benefit that was observed, which led to the trial being underpowered, is one of the limitations. I think the dosing strategy is interesting. Curious about this and like what it would further look like. As we talked about in that phase 2 trial, the 160 micrograms per kilo dose was maybe more beneficial and showed the greatest benefit in terms from a functionality and volume perspective, but it did have that higher rate of thromboembolic events, but also showed similar mortality rate to the other dosing strategies. The pooled analysis of trials later found that rate of arterial thrombotic events identified the increased risk in patients who had a dose from 120 to 160 mics per kilo, factor 7, but it had a very wide confidence interval and showed no significant difference when it was combined with those from a venous perspective. Although the arterial may be at greater risk, but when combining thromboembolic events as a whole, it was not found to be statistically different. So I think in a future perspective, or a future question to ask, is if there's potentially maybe a better dosing strategy to utilize, where we're weighing our clot versus bleed risk in the ideal patient population, and if maybe using a larger dose could expand that population at all. And then finally, I think next steps here. So there are some things to come with the ideal patient population and identifying where this may improve functional outcomes along with decreasing hematoma expansion. And that's where our fastest trial part 2 is coming into play, and which is currently underway, and it's attempting to enroll patients with a positive spot sign on their CT imaging that are able to be treated within 120 minutes, or those that have been treated within 90 minutes with or without a positive spot sign on CT imaging. And they have expanded the enrollment to Finland and Australia to help with patient recruitment. And so overall, I think my takeaway at this time, I don't think factor 7 has a place in my practice at this point. I don't think we've specifically nailed down the ideal patient population for it, but I'm curious to see in time as these trials develop and as more time goes forth and we learn more about the medication to see where it could maybe find its place in practice. And with that, I will take any questions. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.